Okay, I'm going to go ahead. Hopefully this is working. I'm hearing from Loretta and Kimpa too that it's working. So here we go. Tonight we've got several items I'd like to cover. And I will, first of all, this thing has me do a share. Hold on, let me find that share on here. Hopefully you can see that now. It's the YouTube live event for September 11 of 2019. I've got several things I'd like to cover. The first is 36 holes in the roof, or another way of looking at it is IR of the brain, insulin resistance or diabetes of the brain. After we cover that, I'll give you an update on a membership page pilot that we're doing. A couple of reminders, the LACIMT event, September 28th. To find that, you can go to cardiorisk.us/healthylife. When I did that video on it, introducing it last week, I gave you the wrong link. I gave you cardiorisk.us/forward. All that link will do is get you registered, and they'll send you an email whenever they have, whenever we have an event, no matter where it is in the country. The first event is scheduled at September 28th in Anaheim, LA, and it's on. To register and get your time to get the CIMT, go to cardiorisk.us/healthylife. The Louisville event, just a quick reminder on that, November 8th and 9th, and you can find that at our website, prevmedheartrisk.com. The last thing I'll cover is a webinar pilot. Again, in this constant quest to try to get better access and lower costs with high quality for folks to be able to get their own information regarding, do I have insulin resistance? Do I have cardiovascular inflammation? Do I have plaque? So 36 holes in the roof. Now that's a quote that comes from Dale Bredesen's book. Some of you I'm sure have read it, The End of Alzheimer's. He gets a little bit deep and detailed in terms of looking at just about every lab plus the kitchen sink. But there's a lot of very, very good information. I was in the first, well, I'll tell you about that in just a minute. What does 36 holes in the roof mean? Well, I'll tell you about that in just a minute as well. Why do we call it insulin resistance or diabetes of the brain? 80% of folks that have Alzheimer's are known insulin resistant or diabetic. The 36 holes in the roof comes from a quote in the book. There are at least 36 mechanisms contributing to Alzheimer's disease. So fixing one has little chance for success, fixing just one. The laboratory results reveal the sizes of each hole for each person. Now, so this is like the same thing with heart attacks and strokes. You're much better off preventing this than trying to get a cure. Now, there's a couple of things that are helpful to remember about prevention and mild cognitive impairment. Here's the continuum. You start off with preclinical. You're getting some insulin resistance. You're getting some impact on the brain itself, but not enough to have any symptoms. Then you go into what's called mild cognitive impairment, or SCI, subjective cognitive impairment. The typical thing you'll hear from someone with SCI is, I keep telling myself, I'm not remembering names as well as I used to. Or I've always been really good at math, and I'm just not able to click on some of the math the way I used to. I asked my friend, and he said I'm crazy. He said I'm just I'm sharper than others in this area, and I'm just as sharp as the next guy. Here's the bad news. And you could ask your spouse. I think if I asked my wife, she would tell me I'm, spouses are going to tell you, they're going to see a whole different perspective. So maybe ask somebody who's not quite as emotionally connected. Here's the thing. If your typical story for someone with mild cognitive impairment, or SCI, subjective cognitive impairment, is that they're right. They are losing some mental quickness, some mental agility, and again, they're the first one to notice it. Once you get to full-blown dementia, again, that's, as we talked before, there's 36 holes in the roof. It's very difficult to start patching every one of those holes, dealing with, there's a perception about fungus and mold and a bunch of other stuff. We don't focus on that. We have provided a lot of services in this Alzheimer's area, but we're focusing now mostly on subjective cognitive impairment and insulin resistance. So just speaking about insulin resistance and the overlap, I started to mention that I was in the first training class that Bredesen had for physicians and providers to get into the network to start providing this care. He came up to me after the event and he said, what did you think? And I had to say, look, I was a little bit surprised that there was actually so little information on insulin resistant. And, and I was giving what I consider to be a gross underestimation. I said, isn't it at least 50% of the cause related to IR? And he looked at me kind of funny and he said, well, I think it's 100% related to insulin resistance. 80% are known insulin resistant. The rest are what we call CNS insulin resistant. In other words, central nervous system or insulin resistance of the brain. Now, my response at that point was, yeah, or they also had insulin resistance in their body, but people are just measuring it, looking at hemoglobin A1C or fasting glucose. Again, they're missing a huge portion of this problem. One other distinction to be aware of as we consider this is that insulin in and of itself has a totally separate function within the brain, and it has to do with memory. So again, there's a lot of dots to connect. And to be very frank, in terms of the full science of Alzheimer's, we haven't connected all the dots. We spend what, 2 or 3 trillion, or is it a year? I don't know. Somebody check my facts on that. It's a huge amount of money trying to get deeper in terms of understanding Alzheimer's. They've focused a lot on amyloid beta and some of those other biomarkers. Bottom line is they haven't developed a cure, but it's pretty clear that reversing insulin resistance is a major preventive measure. Now, this is an article from Nature magazine. You don't really get better than Nature magazine in terms of hard science. And more articles are appearing labeling dementia, Alzheimer's as, quote, type 3 diabetes. Now, this gets into a lot of the detail in terms of some really geeky biomarkers linking the two, insulin resistance and diabetes. We're not going to go there tonight, but again, just to give you some of the science or a brief 50,000-foot look at some of the science linking the two. Now, a couple of comments about how a couple of measurement components. You may have heard of the MoCA before. MoCA stands for the Montreal Cognitive Assessment. It's one of the key tools that you use. It's like one of the 2 major tools you use in terms of cognitive impairment. You may remember last year, the president, the story came out that maybe he requested one of those. I'm not sure, but he had a MoCA. He had a cognitive agility test, and they said he scored very well on it. I'm not going to make any comments. Obviously, I could make a lot of comments, but this is a topic on science. It's not political satire. So, Montreal Cognitive Assessment. What does it look for? Short-term memory, executive function, orientation, clock drawing, attention span, language, ability to abstract, and animal naming. So some memory type of things. Now, this is a highly standardized test. You have to get certification in order to give a valid score. Janice, my wife, Dr. Derrickson, does have one of the few people I know that does have certification and training in providing this test. And that's part of what we have, services we've provided in the past for people with cognitive impairment. Now, one of the other major assessment item unique to cognitive impairment has to do with hippocampal volume. The hippocampus is the part of the brain that literally connects the dots. It provides the connection between multiple thought centers. And so if you're going to have a problem with memory and connecting the dots, it's likely to go through the hippocampus. Now, if you look at this, you already may have seen it. The hippocampus of a normal control is very, very different from the hippocampus of someone with Alzheimer's. So again, that's another way you can take a look and start getting a little bit better assessment of just what sort of equipment capacity you have up there. So that's a little bit about type 3 diabetes, insulin resistance of the brain, Alzheimer's, cognitive decline. So I wanted to talk for a few minutes about a pilot that we have going on. You can go see that now, I believe. It's a membership page. Basically what we're doing is we're putting all of our digital content on one page. So for those of you that have bought one of the courses, you can go in and see the course here. If you haven't bought a course but you're interested, you can get free previews of the courses. It also will also be adding a lot of free infographics. I just worked on editing some of those today. They still have some need for edits. And as you can tell, we're growing fast in some areas that we haven't tended to grow before in terms of these digital products. They're going to be a little bit rusty, a little bit rough until not so polished until we get up and rolling. So please be patient with us when you see a need for edits. But the new membership page is a great way to start figuring out how to access our stuff. How do you get there? If you go to the webpage, it's prevmedheartrisk.com. You'll see a new button. Click on membership login right there. That'll take you to a place where you create your free account and you just give your email, free account password, and there you go. A couple of quick reminders, as I mentioned, with the November 8th and 9th coming up for Louisville, the event. You can get your CIMT, all of your labs, and spend 2 days in more of an intense boot camp type of environment, talking about how to interpret these labs, how to interpret the CIMT, getting a report from a radiologist on these interpretations. There will be one-on-one meetings with me, many at the meeting and some after the meeting. We did put a special in there for this is the country of vices, horse racing, liquor, and I can't remember what the other vice was, but people that have an interest, we bought a free Evan Williams distillery tour. Why we would do that on a health, I don't know. But if you have an interest, you don't have to drink any of the bourbon. It's sort of like the Disney of distilleries. It's set up to help you understand the history of this region. Cardio Risk US Healthy Life. I mentioned that earlier. On September 28th, David Meintz is going to be giving a half-day event in Anaheim. The registration is $245. That will cover the CIMT and the reading. Also a half day of discussion about what we do. Inflammation, insulin resistance, your CIMT, and we're going to try to set it up to where Todd and I can attend remotely. Whether we're able to get that to work or not, it's hard to predict at this point. Again, we got a lot of things going on. Now, the last thing I wanted to make you aware of is our webinar series. And this came up. I'm not sure. I think it may have been Bart Robinson who asked about the webinar. I mentioned that a couple of weeks ago on one of the live events. And this all started when one of our guys mistakenly published an old video that John Lorscheider had done. It had to do with how to get labs on your own. And it mentioned getting an inflammation panel from Quest. Several people latched onto that, gave Quest a call, and it's outdated. Quest is not given individual access to the inflammation panel anymore, but they still are giving it through us. So as the discussions continued to happen on that, I started to think, you know what? We have a contract with Quest, and I could provide access to the inflammation panel and an insulin survey through our contracts. So that's what we're planning to do, and then set up a series to go over the series of webinars to go over the results. So here's what that is. The goal is to provide actual measurement and interpretation of labs and imaging to folks. Again, better access, lower cost to you, and continued high quality. So the registrants would access their individual labs and imaging results. They then attend a webinar to talk about interpretation. The target time for these webinars would be 45 minutes. The topic would be, the first one would be an intro to describe how the process works. The second one would be a summary. Then we can get deeper in follow-ups with one on plaque, one on insulin resistance and diabetes, and one on cardiovascular inflammation. So what's the process? Sign up for the webinar. If you want to get labs or lab orders, then you contact myhealth at prevmedheartrisk.com. Contact Joseph or Michelle. Then you can get your inflammation panel, OGTT with insulin, or the calcium score. We talked about setting up the CIMT. That takes a little time, and we're just not ready to do that in volume at this point. So then you get those, you obtain the results, and then you attend the webinar. You can obviously attend the webinar without those results, and you can obviously attend the webinar before you get the results and after. What are the times and dates that we plan to set those up? We don't know yet. Clyde's going to send out a survey. And right now we're planning on starting Tuesdays, 11 Eastern time. Now I know we're 147 degrees west. That's pretty tough for Alaska time. And Laura Dillingham, I know that's, I would guess that's going to be like 11 a.m. or something. I mean, 11 p.m. maybe. So it may be tough for the Australians as well. But again, sign up, get set up with the membership page, and we'll start getting the surveys out, and we will adjust as we need. What's the price for this? And that's to be decided. We're working on that right now. Again, it's going to be much less than our intensive one-on-one, doing the whole thing one-on-one with me. The first free for the webinar itself would be, or the first 10 for the webinar itself will be free as a pilot. The lab costs will be to be decided as well. Will we cover other topics? Yeah, if it's successful, we plan to open it up. Isn't this actually practicing medicine? No, doing the webinars, not really, until I will not be talking about anybody's individual results unless the individual brings it up. If the individual brings up a question about a specific result, we will be able to discuss that on the webinar. Orders and individual reports is getting more closer to practicing medicine. One of the things we have to do is get your demographics and set you up as a patient in our EMR, electronic medical record, in order to provide those lab orders. So for the lab orders, and if you get what we call cash labs, just pay us, that will actually be more expensive than the webinar itself. Again, we're working on pricing and access. We'll keep you posted on that. How will it be scheduled? How will we be notified? Videos, routine schedule, like same time slot each week. Facebook, Twitter, etc. How long for each topic? Again, the target 45 minutes for each webinar, with about 20 minutes, maybe 30 of me talking about content, and then the rest of it set up for Q&A Will there be, speaking of which, will there be Q&A? Yes, there will be. I believe that is the end of the slideshow, and I hope you guys have been able to see this. Let me go back and let me see. I hope this doesn't. So live on streaming service. Hopefully. Uh-oh. Well, did I lose everybody? I don't know. Okay. I'm going to read off some questions here. Oh, there's been a lot of activity. I see it. Thumbs up. Yes, I do. Hi, Doc. Homayun Sidki. Mr. Sidki, how are you? Hello, Dr. Brewer. Why don't my cardiologist and GP know any of this? I have to be careful what I say about that. IR is not even a part of their vocabulary. Thanks for all the info. Thank you for the comment. And, you know, here's the thing. The bottom line is if you've got 20 or 50 patients in your waiting room who need a stent, or they've got full-blown diabetes, you tend to just sort of pass quickly through somebody that may have much lower levels. But the problem is, it's the lower levels. It's that 20 years of insulin resistance that creates the risk, the plaque, the inflammation. Adam Scott, and let me just ask you this, guys. Please let me know if you can still see and hear me. I'm going to cover a few questions here. I think we had one from Adam Scott. In your opinion, could you increase attention span through your diet, like foods high in tyrosine or something? Well, you know, the biggest thing, actually, I just worked on my my cognitive decline deck this morning, and there's a lot of things out there. If you read Dale Bredesen's book, he talks about ashwagandha, any of the things that impact insulin resistance, like cinnamon, berberine, all of those. There's one, phosphatidylcholine is considered to be, quote, brain food. The reality is that all of those do appear to have some impact. Here's the thing, though. The major driving force under all of this is that 20 years of very mild insulin resistance, pecking away at your brain just the way it pecks away at the arteries, the internal lining of the arteries. So the major focus is to manage that insulin resistance. There's nothing more important to managing that insulin resistance than diet. So number one, if you have insulin resistance, don't eat carbs. If you can't metabolize carbs, don't eat them. Number two, keeping your BMI at a good level. For most of us, that's in the low 20s. If you're Arnold Schwarzenegger and you're at peak level, I mean, when he was at peak and won Mr. Olympia, he was actually at a BMI of 30. Most of us don't have that kind of muscle mass and that kind of fat mass. The goal is to maximize muscle mass and decrease fat mass, because muscle has actually an insulin-like function, pulling blood sugar out of the blood and into the muscle. And fats have an inflammatory function. I hear that I may have to redo the video I did recently on the secret life of fat cells, but because of some sound tech issues. But the bottom line is, we used to think fat was just a storage cell. Not at all. It is an endocrine cell, and it creates inflammation. It also creates insulin resistance. So Loretta Dillingham, who or where does an X-ray of the hippocampus get done? I don't know about about Australia. I do know in the U.S. most places that have, especially a freestanding radiology unit with an MRI, most of those do have some access to the hippocampal volume study. Kelly Clover, answer to Sidkey. Mainstream doctors are beholden to treatment guidelines, which have little to do with reality, but it enriches powerful special interests, including big pharma. It's a good point, Kelly. I was involved when I was at Hopkins. We had a contract. My residents actually developed the first set of literature reviews, the understanding of the science that the first standards of preventive medicine, the American College of Preventive Medicine, were written on. Standards committees are just like any other human event. They are political. They have a human political involvement. And when you think about it this way, you can understand why it still takes at least 15 years usually to get new developments from science into medical standards. And that is, you pick the experts in an area, and those experts usually have to admit that either their competitor sitting across the table or somebody who's not even in the room discovered something that they think they should have discovered, and they've got to acknowledge that it's important and true. So, you got some big egos sitting around standards tables, and it's a slow human process. Most of these things are changing, but you have to be patient. Neil Higgins, pardon me just a second. Neil Higgins, this is not soda, by the way, no sugar in this. This is a sparkling water. Neil Higgins, my cardiologist said a heart-healthy diet would be a good idea. Put me on Crestor and beta blockers. I dropped all crappy carbs. My CRP, C-reactive protein, is now the lowest it's been since 2012 when I was diagnosed with PMR. Well, very good. Congratulations to you. It says we've got, several dozen concurrent viewers, and hopefully we're still broadcasting, so I'll continue. Adam Scott, anyone know if he answers questions from this live chat? Adam, yes, I do. If I can wade through this confusing technology, see a live chat question like this one, and answer it, I certainly will. James Cantor, Neil Higgins, what does PMR stand for? Neil Higgins, that morphed into rheumatoid arthritis this June, had a CAC over 2,000. So Neil, thank you for sharing that. The others, it's a really, really good point, Neil. The others don't, and PMR, you meant polymyalgia rheumatica. So here's the thing. Most people know that diabetes sets you up for a heart attack and stroke and inflammation. Very few people know that the inflammatory diseases, especially rheumatoid arthritis, polymyalgia rheumatica, PMR, lupus, several of the inflammatory diseases create just as much risk for heart attack and stroke as diabetes for the individual person. It's just that so when I talk to neurologists, someone else asked, I think Sidkey asked, why don't my regular docs know this? Actually, if you talk to your neurologist and your rheumatologist and especially rheumatologists and dermatologists, both tend to know a lot more about the cardiovascular inflammation side because they deal with inflammatory diseases all the time. The endocrinologists sometimes know, but the problem with endocrinologists is they're in the same position that your primary care doc or your cardiologist are. They've got a room full of 50 full-blown diabetics and really don't take the time to focus on the more subtle challenges like we're working on and what you have to work on if you're going to prevent these issues. Okay. Sidkey, I hope that gave you the reply you were searching for. Yes, Adam, Dr. B will canvass these questions, answer what he can. Neil Higgins, I lost 28 pounds since my CAC score, off all sugars and flours, etc. You know, Neil, losing 30 pounds is a life-changing event. And I've got, now since most of my patients are coming in through the YouTube channel, it's like over half of them have already lost 30 pounds before they come in to see me. You know, my obvious first reaction is, well, you may have just saved 2 or 3 decades of healthy life. What can I do for you now? And the answer is always the same. Yep, I'm obviously really focused on this. I want to get healthy. I know I've done a whole lot. I know I've done most of the hard part, but I want to dial it in further. And you can always dial it in further. So that's what I'm ending up doing these days. I'm spending actually less time talking about inflammation 101, which I used to a couple of years ago, and much more time talking about the subtleties. And it's the blessings of the YouTube channel, the folks that already come to me knowing a lot more than folks used to in the past. Neil Higgins, cardiologists and rheumatologists haven't even mentioned if I might be IR. Yeah, the rheumatologists and dermatologists do understand inflammation, but they still don't understand subtle IR too well yet. Most of them don't. Some of them do, but the vast majority don't. James Cantor, Neil Higgins, are you over 65? Well, Neil will have to answer that. David Wyman, hi Doc, love your work. You are a true pioneer. Well, thank you very much. I will say thank you again. I'll have to say that when you tell me that, it reminds me of the old adage that pioneers get arrows and end up face down in the dust, and the settlers, I forgot how it goes, but sometimes I feel like, yeah, I'm getting all the arrows from the pioneer role too. Loretta Dillon Ham, no, still here, okay. Neil Higgins, 59, lifelong athlete, avid cyclist, asymptomatic for heart disease. Good for you. 147 degrees west, there you are, still see and hear you. Joey Boombots, no, I'm here. IR, interventional radiology, no insulin resistance, IR. And pardon me, I try to get away from acronym E's, but especially with IR, I start using that word, insulin resistance. Neil Higgins, part of the problem is our so-called free Canadian healthcare system. Neil, my brother lives in Canada. There's actually some really good components to that Canadian healthcare system. One of them is in Canada, they get Livalo, pitavastatin for about 1/10 of the price that it costs us here in the US. Peter Laness, New Zealand, loud and clear. Good to hear from you, Peter. Richard Lund, LA, it's reported that it protects the function of endothelial cells after a meal. I'm not sure. Oh, gamma tocopherol. Okay. Sidke, thanks, Dr. Brewer. Sidke, yes, thank you. Bart Robinson tuned in and got my full attention. Thank you, Bart. I hope you were the guy that had the questions about the webinar pilot. And if you weren't, I'm sorry, but I hope you're interested in it anyway. Again, hopefully a big increase in access, big improvement in cost. Mr. Y. Tully, question. Can you talk about the Sugar Buster supplement you posted yesterday? Okay, Gymnema. I first heard of Gymnema a few years ago. Gymnema is it's a dried, usually you'll get it as a dried powder. It's I think, isn't that the one that's the cow plant, COWPLANT? Anyhow, what you get, it's something that's been used for over 1,000 years in Ayurvedic medicine. The reason it's called the Sugar Buster is it does have one very clear mechanism and role. It coats these sweet receptors, which you tend to find in the back of the tongue and the palate. After swallowing or swishing around some of that Gymnema powder, you pretty much lose the taste for sweet. Now, I was just reading comments on that video, and somebody said, well, doesn't that make things taste differently? Sure does if it's something that was sweet. I will tell you, I have been a sweetaholic my whole life, and that's not really good for an insulin-resistant person, pre-diabetic like I am. I can tell you, I mean, it's been a battle as long as I can remember, at least 30 years. And I know it's been a battle when I was a teenager to try to stay away from sweets. I wish I just this past week started trying that Gymnema, and dang, it helped. It's not the battle that I've been fighting for 45 years. I wish I'd known about it long ago. Now, there may be some other biochemical or biological mechanisms, central mechanisms after it's absorbed in terms of maybe impacting absorption of sweets down in the gut, absorption of sweets in other places, but that's not very clear. It doesn't matter to me. It's helping me impact that and get away from that battle over, oh, I want something sweet. Oh, I want something sweet. Okay, I hope that answered your question. I have also lost 10 pounds and am on your protocol. Since your channel, see you in future before I have a heart problem. Well, good. I do look forward to seeing you, and thank you very much for sharing that. Colin Whelan, do you think a lot of health issues occur because people are unaware they're not hydrated properly? You know, you clearly have problems with young people, like young athletes doing 2-a-days in 100-degree weather, and a young athlete or young people that think that it's not an athletic event, but then they decide they want to go rim to rim in the Grand Canyon. Those are places where you get tragic events with that and heat stroke. And heat stroke occurs in a lot of work areas, but that's one thing. And that's and you're going to say, well, I'm not talking about that. I'm talking about maybe even a heart attack from being dehydrated. There is if you look it up on the web, you Google it, you'll see, a lot of claims that you can get a heart attack, from being dehydrated. That's not true. Okay, Colin Whelan from the Republic of Ireland. Glad to have you. And I was going to try to say something silly about some sort of Irish greeting, but I'm not good at any of that. So thank you very much for telling us you're from Ireland. And again, very glad to have you. Neil Higgins, is that statin you mentioned better than Crestor? Here's the advantage to pitavastatin or Livalo. The advantage is this. All the other statins sort of continue to push you down the insulin resistance diabetes highway. Even Crestor. When I use statin, it's almost, in the past, it's almost always been, well, at least for the past 2 years, it's usually been low dose Crestor. So low dose Crestor is not going to push you that far. Over the past year, well, here's what happened. A few years ago, a new statin came out, Livalo or pitavastatin, and it had a major advantage. Not only does it not push you down that insulin resistance highway, diabetes highway, it actually starts to pull you back. It actually decreases insulin resistance. Now, I haven't used it much. It came out more than a year ago. I didn't use it in the beginning for 2 reasons. Number one, it cost a huge amount, and I had very few people whose insurance would pay for it or wanted to pay for it themselves when they had a perfectly good option like Crestor. The other issue was this. The major reason I give statins is not to manage LDL. That's not really the issue. The issue is to decrease inflammation. Inflammation is where you're taking friendly fire. Your body is attacking, the immune cells in your body is attacking LDL that has lodged in your artery wall. You've had a challenge to the glycocalyx, usually due to having a few hours of a blood sugar 180 or above, 140 or above. And if you have a few hours of that, they've got pictures of the glycocalyx before and after, and it looks like somebody came along with a lawnmower and just cut out major chunks of the glycocalyx. When that happens, LDL that is in your blood, no matter what concentration it is, it can go through that glycocalyx and lodges in the artery wall. So that's why they always originally thought that cholesterol was the problem, because plaque is made up of oxidized LDL lodged in the artery wall. So they thought originally, well, you are what you eat, and this must be coming from the bloodstream after you eat it. Then they found out, well, actually, we make far more cholesterol than we eat. That started to take a chunk out of the cholesterol fad. The next thing was we recognized that half of the people having heart attacks have normal cholesterol values. So yet another big chunk out of the LDL theory. And I can tell you, I've got plenty of patients that have FH, familial hypercholesterolemia. These people have an LDL of 250, 300, 350. They still tend to not have a problem in their early decades, and still not have a problem with events or even inflammation until they start getting into their 50s and 60s, or they start getting obese. In other words, they start getting insulin resistant. We've covered several folks with FH on the channel. I'm blanking on her name right now, but one lady shared with us that, Sue, she shared with us that she was a big smoker. She had ended up having to have she had an event. She had to have stents, and then surgery multiple times. But that was because she was smoking. She had a smoking habit in addition to her FH, her high cholesterol. She dropped her smoking, had her surgery, but then she started gaining weight. She went from 125 to 250, and she went about 15 years from her first event, I think was in her mid 30s. Her second event was in her 50s. And again, she weighed twice what she had weighed before. So she was a great example of how the cholesterol itself is not what got her. It was when something else was added to it, like cigarettes or obesity, leading to obviously insulin resistance. I think I've gone off down a bunny trail. Would you consider low dose Crestor? I've always used low dose. Well, for the past couple of years, that's been 90% of what I've used. Crestor has a half-life of 17 hours. So you can actually, I've got several people on a standard low dose Crestor dosage is 5 milligrams a day. I've got plenty of people on 2.5 a day, some people on 2.5 or 5 twice a week, 3 times a week. And I even have a few people on once a week. The research has been done. It's shown you actually do get a positive impact, even with once a week Crestor. Now, can you do that with the other statins? No, not unless the half-life is that long, and it's not that long in most of them. James Cantor, Bart Robinson, I am now a diabetic under control with an A1C of 5%. AGTT was never suggested and not sure if I should ask for it now. James, at some point with my folks, even that are standard diabetics, I do get one every year or so because we want to understand just what kind of shape your pancreas is in, what kind of shape your insulin resistance is in. Dr. Sidkey, does low-dose Crestor cause muscle aches, fatigue, and associated side effects you find with higher doses such as 80? Much lower set of problems, Dr. Sidkey. Great question. Thank you. Amazon, just turned 80. My calcium score was 69. In 6 months, I've gone from 185 to 137, and my wife thinks is low enough. Is there a weight you would consider a stopping point? For most of us, the low 20s in terms of BMI, and you can look that up on Google. Just Google BMI calculator, and it'll give you a section, enter your weight, enter your height, and it'll automatically pop up your numbers, your BMI. So for most of us, target that. If you've got as much muscle and as little fat as Arnold Schwarzenegger had when he was Mr. Olympia, slightly different question. But with either of them, you can use a SPECT scan, but RFM, relative fat mass, is technically the best thing to use. But that hasn't caught on yet, and that's going to be a few years before it does. If you want to look, I've got several videos on BMI, body mass index, and RFM, relative fat mass. Mr. Y. Tully, question, all cardiologists, most, agree that magnesium supplements are important. Did you look into Dr. Caroline Dean's magnesium, REMAG? It had been a game changer for me. I'm not affiliated with her. I'm not affiliated with her either, and I haven't looked at her specific one. I do know that there are several important impacts of magnesium. And here's the thing, even, I don't know anybody that would say that the typical American is not magnesium deficient. Magnesium has impact for both, for the GI system, for mental health. Too little magnesium it can cause depression and or anxiety. And even the CDC, the NIH, all of us would say the typical American is magnesium deficient. So if you're not taking magnesium, if you're not aware of what we just talked about, check it out. Bart Robinson, James, hopefully Dr. Brewer will give his take on that. Oh, I think that was the question about should a diabetic ever get an OGTT? My 147 degrees west, my son smokes. That is so frustrating. I have a personal close family member who smokes as well. And when he started, it was like, what could I be doing wrong? I cannot believe this. That's just so heartbreaking. There is a major, there's a resurgence of smoking, especially in teenagers right now. And it's, you know, gosh, it was just a few years ago that that obesity took over from smoking as the #1 cause of risk factor driving death and disability. And it's like, just when we thought we were getting a handle around smoking, it's don't go back in the water. It's coming back. It's like Jaws. Neil Higgins, Dr. Brewer, what is your exercise routine? So I live in a condo complex which has a wonderful walk. It's about a mile. It was several different walks here. One of them is 1 mile. Another one is about 3/4 of a mile. And what I tend to do, my kids laugh at me because they laugh. I get paid to talk. I'll tend to put my my headphones on long phone calls and walk. So I get a lot of walking, usually several miles a day. I stand. You may have noticed that I'm not sitting. I don't sit on any of my presentations because sitting is the new smoking. Sitting's bad for you. So I do those two things. Here's what I do. Twice a week, I'll have sessions where I do high intensity intervals and resistance training. The high intensity interval is sessions are about half an hour. It's mostly treadmill. I start off on we don't know exactly what level these inclines are, but it's a treadmill at a marking of 1/2, and then 8.5 miles per hour and 5 minutes. Then a couple of minutes of slow. And then the next 5 intervals will be at 10 miles per hour. That's a 6-minute mile pace, but only for 1 minute, not a whole mile. And then 1 minute of slow. So 10 miles per hour on usually a half, the first level of incline, and then back. After I do those 5, then I'll do a couple of 2 to 3 minutes at a level about 5 to 6 times higher. It's a significant incline. So I'm getting more and more incline in the in the high intensity interval. The other thing I do is a lot of resistance training. If I've got a couple of videos on sarcopenia, loss of muscles, and ways to prevent that. And one of them, if you look at a couple of the guys that have hold a lot of world records in terms of both bodybuilding, like Arnold Schwarzenegger, or lifting multiples of your weight. That's a fellow named Richard the Ant Hawthorne. I've got a couple of videos on those guys, and they both use a thing called the Austrian, as in Vienna, Austria, the Austrian volume method. Most people think that you do a set of 10 or 8 or 10 for your upper body and sets of 12 for your lower body, and maybe do 3 sets. Both of these guys say, no, that's not it at all. You go for about 100 reps total. The first 40 reps, it's light enough to where you feel like, I hope people aren't looking at me because I'm lifting so little weight, and you feel like you're being silly. But what you're doing is depleting glycogen in your muscles as you do that. Then the next 40 are, it's not like you're really pushing it out, but you feel it. And then the last 20, you do as much as you can. So, and I do squats, bench press, on a lot of Cybex machine type work. So that's the workout. I do that twice a week, and then I do a ton of walking. What do I think of Wellbutrin? Wellbutrin has been a very, very helpful tool in terms of smoking cessation. Dr. Farm CDE, cheers. Also, James, if you're a type 2 and A1C should be 4.5 to 5. Yep, that's the goal, Dr. Farm CDE. Currently taking metformin, ER 500 twice a day, and Ozempic 0.5 milligrams a week. Richard Morris, hi, Dr. Brewer. Would a person with NAFLD produce diabetic symptoms like a high A1C, or would it be the reverse of a high 1C causing NAFLD? Because I believe I have fatty liver, but don't know what came first. Fatty liver is one of the, I've got several videos on fatty liver. It's one of those things that's very, very much related to this diabetes and insulin resistance and obesity epidemic. All the things that you do for diabetes and insulin resistance are things that help with fatty liver. Actually, there's some interesting statistic. Was it liver cancer has become, I don't know, it became like one of the top cancers or cancer deaths among women or men. I don't know. Again, I can't even remember the fact for you to fact check me on. It's the meeting's getting long in the tooth, guys, especially if we go over an hour. Folks tend to not want to take a look at it if in the reviews and replays. Thank you very much for your interest. Check out and keep your eyes open. Be thinking about the webinars. It's a great way to start getting a handle on where you are yourself. Thank you.